present with oral candidiasis as such. So then I would look for more rarer conditions which can present with recurrent candidiasis. That would include like chronic mucocutaneous candidiasis as a presentation, which can be often seen. But these are again very rare scenarios. Most of it is hygiene related in our scenario, and if we sort it out, that gets sorted out usually.
Yeah, but I would say that candidiasis going on for so many years warrants evaluation. If it was infancy, I think in a well-thriving child, an infant, a bottle-fed child, maybe that is one place where we would not investigate. But beyond a year, persistent oral candidiasis needing repeated antifungals, one must get worried. Now to add to this, I can tell you that there was no consanguineous background in this family, but then the nails did not look up normal. In fact, this child had onychomycosis. So the fungal infection was not only affecting the oral cavity, but even the nails. Now Dr. Mukesh, what are your thoughts?
Right. So we have oral candidiasis, we have nail infections. So here, as a general physician, I would like to think of immunodeficiency state, in which I would like to see the immunoglobulin profile. I would like to see the HIV status. I would also like to see the neutropenia or the leukopenia, if at all it is there. And if I do not find that, definitely chronic mucocutaneous candidiasis, I would like to think of a genetic cause. So I would like to further move ahead with a genetic evaluation.
Yeah. Now, as highlighted, we looked at the hemogram. There was no neutropenia, there was no lymphopenia. Sometimes combined immune deficiencies can present later. So, as Dr. Neeta ma'am highlighted, SCID, severe combined immune deficiency. We use the word severe because they often present in the first 2 years and they die if we don't diagnose or transplant them. But then we have a whole group of combined immune deficiencies which are not severe and they can have a later age at onset. Now, you look at the HIV that was negative. Serum immunoglobulins was normal and even the lymphocyte subsets were normal. But then this does not stop here, because this degree of candidiasis that is going on for years should bother us, and when it bothers us, we went ahead and did a genetic test and it showed something known as STAT1 gain of function mutation. Again, I would like to tell the audience that we are not really trying to highlight what is STAT1, what is IL-12. That is not the message that we want to give. The message here is that if you have persistent candidiasis, onychomycosis, start thinking of an immune deficiency. Just the thought of an immune deficiency, we can make the difference. Testing is very easily and readily available these days. Now, Dr. Arpita, what diseases can present with chronic mucocutaneous candidiasis? Obviously, HIV is one of them and we have ruled out, but then what other diseases? I will put the list here for you. Yeah.
So, chronic mucocutaneous candidiasis usually, which occurs due to commonly Candida albicans. So, usually the pathology would be somewhere where there is a defect in Candida recognition. And a defect in Candida recognition, so the main processes of the adaptive and innate immunity that is involved is the T helper 17 pathway. So if there is a defect in the proliferation of T helper 17 pathway, or if there is a defect in the synthesis or the signaling pathway involving interleukin 17, then in those diseases, most commonly we see chronic mucocutaneous candidiasis, and the examples of them being the, as you have already enumerated, so the STAT1 gain of function mutation, which is the most common, and in both autosomal dominant and autosomal recessive forms of hyper IgE syndrome, which can be actually even recognized clinically. So patients with hyper IgE syndrome have a characteristic facies. They are prone to asthma, eczema, they have multiple skin abscesses. So, and the defect here again lies in the T helper 17 pathway. Apart from that, the autoimmune polyendocrinopathy with candidiasis and ectodermal dystrophy, these are also some of the diseases which cause chronic mucocutaneous candidiasis.
So what is interesting about this group of disorders is that one must question why don't they get invasive fungal disease, though it is possible, but it is quite rare. Now you will all agree with me, when we give chemotherapy to our patients, they become neutropenic. Beyond a few days, we start getting worried about fungal infections. And especially I think aspergillus is something that we worry. Now that is an invasive fungal disease, where there is an invasion into the bloodstream, dissemination into the tissues, and there the problem was neutropenia. So if you have neutropenia, you have invasive fungal disease. If you have Th17 pathway defect, you have surface candidiasis, and usually you don't have invasion. So that means these patients are a distinct group where Th17 is playing a very important role at the initial site of entry, whereas neutrophils play an important role within the bloodstream. Now again, these diseases are not important. This is just to tell you that there is a whole lot of diseases. When you ask for a genetic test, please write down these differentials. These days writing an exome has become very easy, but when the lab is not given adequate information, they often come back with unnecessary VUSs and negative results. So that is why it is important that we know why we are asking a genetic test rather than just ask a genetic test. So to summarize here, CMC, rule out HIV, do a quick immunological screen which could be lymphocyte subsets, immunoglobulins, NBT and DHR, and if that screen is negative and your suspicion is still strong, you can go ahead and do a genetic test, which is often an exome sequencing in our setup. Let's go to the next case here. This is a 2-year-old boy, again who seems to be unwell from 3 months of age. He had severe itching and rashes all over the body, and he was being managed by a dermatologist for possible atopic dermatitis. Now Dr. Kaushal, how commonly do you see atopy in your practice, and do you always investigate such children for an immune deficiency?
Sir, atopic dermatitis is quite common, and globally if you see it is somewhere 10 to 30% of children can have at some stage or the other. And every time, definitely, frankly speaking, we don't go further, sir. And it's a disease characterized by intense pruritus, and there is problem with the skin adaptive mechanisms and skin barrier. And investigations we only do if there is something else is there, right? Like recurrent infections are there, then only we move further in these cases. Otherwise we don't.
I think that is a very clear message here, that when we have only atopy, we often don't investigate extensively. We manage the atopy, and then often you get a positive family history. You can look for these children evolving to asthma, allergic rhinitis, what we call atopic march.
Atopic march sort of things comes, and then we stop there.
Now continuing the case, this was not as simple as it looked at the beginning. The index case also had 2 episodes of pneumonia in the past, and there was intermittent epistaxis, and because of this epistaxis, a clinician, a pediatrician had rightly investigated, and they found that there was mild anemia but couple of records of thrombocytopenia, and because of the atopy they asked for a IgE levels which was markedly elevated. And then this was very much sensible on the part of this senior pediatrician that they asked for a peripheral smear, and in the smear they could show that not only the platelets are low in number but platelets are small in size, and that's where they said it's microthrombocytopenia, and the mean platelet volume, which is often between 7 to 11, here it was only reported to be 4. So Dr. Ramesh, over to you.
Clear.
So it is fairly easy for me now, because there is a skin infection, recurrent infection in form of pneumonia. Platelets are less and they are of a smaller size, though it is not necessary that it should be hypothrombocytopenia, micro. And IgE is raised, so it's a Wiskott-Aldrich syndrome.
Yeah, so this is Wiskott-Aldrich syndrome. Now often, as sir rightly said, now it is very easy for me. I think it becomes now easy only when the whole spectrum presents to us, or when they have gone to several physicians. Now naturally this child must have gone to a dermatologist, possibly to a hematologist, and because of infections to a pediatrician, sometimes to a pediatric pulmonologist, sometimes they have a blood in stool, so they must have gone to a gastroenterologist. So often it is not that straightforward until somebody sits with the child and looks at all the records and says, no, something more than usual is happening here, let's collate. And when you collate everything, it looks very simple. There is only one disease which has got thrombocytopenia and eczema in a boy child, and that is Wiskott-Aldrich syndrome. Now, so that's the triad that we all know: low platelets, eczema and infections. And whenever you suspect this disease, please ask your hematologist to look at the peripheral smear, see if these platelets are small, because often these patients are misdiagnosed as chronic ITP. And we all know in ITP the platelets are large in size because of increased production, whereas here they are small in size. Now this is an X-linked recessive disorder, so only boys will be affected. Mutation is in the WASP gene. There is a triad, thrombocytopenia with small platelets. Sometimes the MPV can be normal, but again diagnosing them in time is very crucial, because these children can be cured with a bone marrow transplant. Now, immune deficiencies, there is a huge list that can present with eczema, but the common diseases here are Wiskott-Ulrich syndrome, the autosomal dominant hyper IgE syndrome, which I think Madam was trying to describe. Children who come to you with, I would say, coarse faces, recurrent cold abscesses with Staphylococcus aureus, recurrent pneumonia and high IgE levels, or the Dockade deficiency, which in fact is not very uncommon, at least in southern India because of consanguinity. We have recently published 20 cases of Dockade deficiency only from our center. That's because it is a autosomal recessive disease. Let's go quickly to the next case now. A 5-year-old boy who comes to us with persistent fever for a month, and this is the patch on the chest X-ray, and because we had given maybe the second line antibiotics was already done, there was no clue what we were treating. We have a very good pediatric pulmonologist, he aspirated and we could culture aspergillus, and this child is coming right from the community, there is no neutropenia. So Dr. Neeta, your thoughts?
I'll ask for prior history, I'll ask for family history, I'll look at how the child is growing also. So if it's a lung infection which is growing aspergillus, first thing I would look for is a neutrophil count, whether there's been chronic neutropenia or not. But this is not really the pattern in which neutropenia causes invasive aspergillosis. It's usually bilateral and it's usually peripheral nodules that you would see in children are more sick as well. In this kind of scenario, I would also look for CGD because that's one presentation where you can have chronic lung infections and lung infection with walling off. So it's like a granuloma kind of presentation that you're seeing. So not even if it's not aspergillus, even if it's like any other bug, the very unusual bugs like Chromobacterium, Elizabeth Kingella, Nocardia, all these things also will look for underlying CGD as a presentation. And since it's 5-year-old, it's usually autosomal recessive that goes till this age. Yeah, the X-linked ones would be very, very sick and they generally present in infancy or before 2 years.